All right, let's go ahead and get started with the case of Dave. Now, Dave's a 41-year-old male. He's being referred by his primary care physician after having gone to the ER for difficulty breathing. We're going to want to start there. The trip to the ER for the symptoms of difficulty breathing is right off the bat, we're kind of imagining whenever a person has difficulty breathing, that, especially having gone to the ER, there's some things that we need to know, particularly when just drawing from knowledge that says that one of the most common visits to the ER that ends up being or mimicking cardiac symptoms or a heart attack is more often than not panic disorder. Throughout my career and through most people who have suffered with panic disorder, they will tell you that they've made sometimes multiple trips to the ER. They've done a full workup with blood tests, EKGs, cardiac stress tests, the whole bit, only to come back that really it was a psychiatric condition, congruent or common with panic disorder or having had a panic attack. So just right there, going to the ER, difficulty breathing lets us know that, okay, we probably are headed in some sort of direction. But let's, as far as being a clinician and taking a step back, we'll see what goes on throughout the rest of this scenario. So with difficulty breathing, it looks like the physician was unable to find a medical explanation. As I kind of stated, usually they get there, they do a whole workup, blood tests, EKGs, and more often than not, then they come back saying that they're unable to find a medical explanation for symptoms. Now, this can be very troublesome and bothers a lot of our clients because it is so real. It feels like a heart attack, or it feels like they are having some sort of physical problem that's very severe, that it's almost a letdown for them to be told it was a panic attack rather than being like, oh my gosh, thank heavens it's only a panic attack. There may be a little bit of that, but there's also kind of this interesting letdown that, wait a second, that was kind of, in my mind or part of a mental condition. So there is that kind of tension that goes on at that point, that a person realizes that, wait a second, am I going crazy? How can this be? It felt so real. So let's continue on. That's a pretty common descriptor there of they're not able to find a medical condition for the symptoms, which then, as we find out, left him feeling confused, stressed, and angry. So as I said, that is really, really common, that people are often confused and even angry. So they're let down, they're angry that was the case, that how could that be, right? How could they not find anything, and how could this be kind of part of a psychiatric or psychological condition? So we see here that over the last 6 months, so that's going to be an interesting statement. So we have some sort of timeline here. So let's see what this says. Dave has had several instances where he's felt an intense fear. So let's mark that down. So over the past 6 months, several instances. So these words are going to be critical. 6 months. Oops, that's not a very good color. All right, here we go. So 6 months here. He's had several instances. So that's going to be key. That lets us know this wasn't just a one-time single episode acute instance. It's been 6 months, several times. Intense fear is a great descriptor, and it would reach a peak within a few minutes. So that's kind of a really significant statement right there. That really is purely the description of a panic attack. It's something that is very much unexpected. It comes on and has an intense peak for several minutes. I've heard clients, mention that they've had a panic attack for hours at a time, which may be the case. I would say it's similar to this, where it has a sharp rise very quickly, and that can go on for minutes, or I would say, maybe upwards of maybe 20, 30 minutes, probably max, but usually a few minutes. And then there's usually that lingering intensity and anxiety where they still feel the anxiousness, but the peak of it lasts usually only a few minutes or so. So we can see here that there was a peak. It lasted for a few minutes. That really is the common classic descriptor of a panic attack. So here we go. We're racking up the symptoms. 6 months, several instances, ruled out any sort of medical condition. So that diagnosis is kind of being ruled out already. It doesn't say anything about substances, doesn't say anything about a goal. So malingering, those first three differential diagnoses are really kind of being checked off at this point. So we're really headed towards a panic disorder. But let's continue on to see how this plays out. So it looks like during these instances, he would experience sweating, heart palpitations, chest pain, discomfort, and shortness of breath. So if you were to look in the DSM-5, 5TR, you would go down the, for example, just keep rolling with this potential diagnosis. You'd go look at panic disorder or a panic attack, and boom, 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 boom. There you go. Sweating, heart palpitations, chest pain, discomfort, shortness of breath, several instances, kind of unexpected. I mean, we're on a roll here. This is kind of classic panic disorder. Looks like Dave is worried that he might die. As we know, this is also a very common descriptor and part of the criteria of a panic attack. This feeling that they might die really is associated with the fact that it mimics very, very closely that the person's going towards cardiac arrest. So that is a legitimate feeling that they might die. Again, the chest pain, the discomfort, and shortness of breath. In fact, if he went to an ER, those descriptions alone would even set medical providers into a cardiac arrest protocol. They would run through all of that and EKGs, the whole bit. They would have probably everything ready to rock and roll. However, once the EKGs and everything comes back, the ER, I'm sure providers start to think, oh, here we go, another panic attack. Looks like as a result, Dave starts to have persistent worry about having another attack. That's certainly part of a panic disorder, is now gaining kind of more momentum that they're worried about having future attacks. Additionally, he's begun to avoid unfamiliar places and people where it might be difficult to get help in the instance of another panic attack. So that is a critical statement. As a matter of fact, I'm going to just have fun here and highlight that because this is now evolving. So this first part of the case study, it's really talking about, the classic panic disorder. So we've kind of checked the boxes for that. It's been happening 6 months. So at this point, I would be almost ready to put that down. This statement here is now leading us towards a little bit of a different path in that now he's begun to avoid unfamiliar places and people where it could be difficult to get out because of another panic attack. So that descriptor there is almost textbook for agoraphobia. So now we have, let's go ahead and write this down. We have almost 2 diagnoses being developed within this same case study. So it looks like panic disorder is almost certain based on the first portion of this case study, right in this area right here. That's almost a slam dunk. Then we have this next statement starting there, beginning to avoid unfamiliar places because of it possibly being difficult to get out for fear of having another attack, which is really one of the primary symptoms then of agoraphobia. So here we go. We actually have kind of 2 disorders now working into our diagnosis. It says that the panics associated and associated avoidance are significantly impacting his life, and he has been turning down social invitations. So we have some key phrases there. The avoidance is significantly impacting his life. So there we go. So there's the DSM criteria that we're looking for as far as how it's impacting him. Is it clinically significant? That statement says it all, that it's impacting his, significantly impacting his life. And how is it? In what area? Well, it's right there. We can see that he's starting to turn down social invitations. So at least socially, it's impacting his life at that point. He's also making excuses to stay at home whenever possible, and relying on his wife and children to drive to their various activities. And this is very common with those who have agoraphobia, is they start to make excuses to stay home, but that's not it. The statement I want to focus on is this right here, where they start to rely on somebody close to them. It's a family member, a friend. They have difficulty leaving the house without having any sort of support person to accompany them. There's just, the fear is so intense that they may have another panic attack and not be able to get out and even get home, that they really do have to start relying, or they feel they have to rely on their family members and friends. And let's go on here. These are the final last statements. It says that the wife was understanding of him at first, but she's grown frustrated with what she perceives as his irrational fear of panic attacks. So this is similar to other case studies that we've seen or that we've gone through here, that she was understanding at first, but then has grown frustrated. And this kind of is the kicker. In addition to the social impact, this is now interfering with his wife and relationship. She's growing frustrated. We can also see that he's become reliant on not only the wife but the children to kind of impact the family, that the wife has to drive the children to their activities. He's not able to, so it's impacting their lives as well. He's not able to attend their events. He's withdrawing and socially isolating. That's part of that staying at home. So there we go. We have probably enough just in this last portion. If we want to go around here, we have enough in this last portion then to definitely look at an agoraphobia type of diagnosis as well. So I, at this point, would look towards panic disorder as definitely kind of the one of the primary diagnoses. Also agoraphobia. This can kind of be switched out. At this point, agoraphobia definitely seems to be making, at this point, the largest impact, because he's not going out. His family is suffering from that. So in fact, in previous versions of the DSM, it was actually the diagnosis was agoraphobia with panic disorder or without panic disorder. So in this case, because this particular diagnosis is having the most impact or impairing his life, I would likely go with the agoraphobia being primary, that he's dealing with agoraphobia, and that he also has panic disorder as part of the agoraphobia. Really, it could be either or. I just feel that the agoraphobia at this point is having the most significant impact and what is causing the most impairment in his life, because socially isolating, impact in his relationship. The panic disorder is definitely going along with that, and most people who are suffering from agoraphobia definitely have panic disorder to go along with that. This would be a great referral to a family care or family practice primary care provider, potentially for medication. This is typically given benzodiazepines to help with the panic disorder. The problem with those is that they're very habit forming, and they start to depend on them because of the fear. They start to use them multiple times of the day, which makes our job as clinicians so hard, because the substance, the benzodiazepine, works so well to calm them down, or at least take the edge off, that they start getting addicted and want that feeling of feeling calm so quickly that it makes it difficult for us to do our job in doing CBT work and other type of work. So we have to be cautious as well, and we kind of have to help educate them. Hopefully their family practice doctor will as well, to educate them of the risks of benzodiazepines, but definitely referral to a family practice doctor along with clinical work is probably the best option in this scenario.